Hello, guys. I hope you can hear me and I hope you all are doing well. So, let's start from where we left the last time. We are studying critical care right now and we'll go scenario wise. So, first, I'll be going through the scenarios and then we'll be discussing about the topic accordingly. So, let me just go through a small scenario here. Okay, so in this scenario, we have a 55-year-old man who was brought up to the hospital after a road traffic accident. And on presentation, he's having shortness of breath, coughing, having severe abdominal pain and chest pain. Pulse rate is high, 145. Respiratory rate is 30 breaths per minute. BP is 105 by 80. Saturation is 85. On examination, certain bruises are seen on his chest and abdomen. There is tenderness at the epigastrium. He has got reduced breath sounds on the left chest, and chest X-ray reveals that the diaphragm is positioned higher than normal, with the gas bubbles visible in the pleural cavity. And mediastinum appears to be shifted to the right side. A chest X-ray was repeated after the insertion of a nasogastric tube, which is visualized to be curled above the hemidiaphragm on the left side. So it's a case of diaphragmatic rupture. It's a case of now diaphragmatic rupture can result from blunt trauma to the trunk. It can result from blunt trauma to the trunk. And a hard direct blow to the abdomen raises the intra-abdominal pressure so quickly that the diaphragm ruptures. So that's what happens, that a very hard direct blow to the abdomen raises the intra-abdominal pressure to such an extent that it raises the diaphragm so quickly so that it just ruptures. And it is seen in road traffic accidents with a seat belt injury. So this is also one of like highlights, like seat belt injury, because in this scenario also it is mentioned that he was wearing a 3-point seat belt. So that can be a cause for the direct blow. uh, so a hard direct blow, uh, hard direct direct blow to the abdomen raises the Intra-abdominal pressure very quickly, which leads to rupture of the diaphragm. Seen in road traffic accidents with seatbelt injuries. Breath sounds on the side of the rupture are diminished. Abdominal contents can herniate into the thoracic cavity, resulting in the shifting of the mediastinum to one side. And if NG tube, nasogastric tube, or what we call Ryle's tube, it is inserted, the tip of it can be visualized in the chest cavity, which is pathognomic for a diaphragmatic rupture. Okay, so this is like a classical feature of diaphragmatic rupture, that if we insert NG tube, the tip of it can be visualized during the X-ray in the chest cavity, and it will be curled. So it is pathognomic for a diaphragmatic rupture. So breath sounds are reduced on the side of rupture. Abdominal contents can herniate into the thoracic cavity, causing shifting of mediastinum to one side. Certainly, if there will be herniation of abdominal contents, it will cause some displacement of the mediastinum, and there will be shifting of the mediastinum to one side. And yes, a very important feature, that if a nasogastric tube is inserted, the tip of it can be visualized in the chest cavity, called above hemidiaphragm. During which is pathognomic of a diaphragmatic rupture. So yes, this point is important. So yes, that was about diaphragmatic rupture. Now we will go to the next scenario. So now here is a 45-year-old woman who was admitted into the intensive care unit from the medical ward for hypertensive cardiomyopathy. She came to the medical ward. She was admitted for hypertensive cardiomyopathy, which was complicated by acute pulmonary edema. She has worsening chest pain, uh, back pain over the past few hours, and she's also sweaty and feeling nauseous. On examination, her MAP, that is mean arterial blood pressure, is significantly higher on her right arm than her left arm. She is hemodynamically stable. So, in this case, the most appropriate investigation would be CT angiography, that is computed tomography angiography. So, in this case, the most appropriate investigation would be CT angiography uh, to look for aortic dissection, as this provides a definitive diagnosis, and the disparity of blood pressure where the right arm is higher than the left indicates that aortic arch is involved. Yes, disparity of blood pressure where on the right hand side is higher than the left hand side. It indicates that aortic arch is involved. Now, if she was not hemodynamically stable, then a transesophageal echocardiogram may be the investigation of choice in theater. So, because here she's hemodynamically stable, so in this case we can carry out CT angiography. So that is important, that patient should be hemodynamically stable. Patient should be hemodynamically stable for CT angio. But if the patient is hemodynamically unstable, then we can carry out Transesophageal echocardiogram. So in this case, the patient was having disparity, or there was difference in the blood pressure in the right and left arm. And in the right arm it was more as compared to left, so it indicates that aortic arch is involved. And as the diagnosis here points towards aortic dissection, definitive diagnosis kind of, uh, aortic dissection, so here CT angiography should be done, or it is the most appropriate investigation in this patient, computed tomography angiography, because the patient here is hemodynamically stable, so we can carry out angiography. But if the patient was not hemodynamically stable and the scenario was same, so we could have carried out transesophageal echocardiogram, that is transesophageal ECG. For stable patients, CT angio; for unstable patients, transesophageal echocardiogram, not ECG, sorry. It's echocardiogram, transesophageal echo. Yes. So this was a case of aortic dissection. Aortic arch was involved. Let's go to the next scenario. Now here is a case where a 65-year-old man is unable to swallow after a stroke. So an NG tube or Riles tube, nasogastric tube, is placed or inserted for enteral feeding. So the most accurate method for checking the correct placement of an NG tube or of a nasogastric tube is chest X-ray. Chest X-ray is the most accurate method for assessing the position of nasogastric tube. There are other methods as well, but they are not the most accurate. Chest X-ray is the most accurate. There are other methods like pH indicator strips or auscultation, uh, or some people even observe for bubbles, putting NG tube the other end of the NG tube underwater. So, but yes, chest X-ray is the most accurate. So first, it is important to always check the position of nasogastric tube after insertion, because a wrongly inserted tube can which is can reach bronchial tree, and it can even result in aspiration pneumonia or respiratory arrest if feeds are given. The most accurate way to assess the correct placement of nasogastric tube is X-ray. The nasogastric tube should be seen midline down to the level of diaphragm, with the tip clearly visible below the diaphragm. That is important. Most accurate way to assess the correct placement of NG tube is chest X-ray, or just X-ray. But yes, to be specific, chest X-ray. It is seen midline down to the level of diaphragm, with the tip clearly visible below the diaphragm. Now, some other methods are like pH indicator strips, which can also be used to determine the correct placement, but it is not as accurate as compared to an X-ray. Some hospitals would use a pH indicator strip as the first line to confirm the position by looking for pH reading of less than 5.5. The pH of gastric acid is around 3 to 5, and pH of bronchial secretions is above 6. So, if the aspirate could not be obtained, or if the pH was higher than 5.5, a chest X-ray to determine the position must follow. Local guidelines differ, and in some hospitals, chest X-ray is required for all the patients following NG tube insertion. And yes, very important that to note here that different hospitals have different ways to deal with the same situation. So yes, it is one of those examples. But yes, as we talked about, chest x-ray is the most accurate method. So even if like we are using pH indicator strips, to confirm we always have to go back to the x-ray. pH indicator strips are also used to determine the correct placement, but it's not as accurate as x-ray, clearly. So in this method, position is confirmed by looking for pH less than 5.5. pH reading should be less than 5.5 to confirm the position by this method. If aspirate can't be obtained, or pH is higher than 5.5, in both these scenarios, either if aspirate can't be obtained or pH is more than 5.5, then we have to do chest x-ray to confirm. Spray to confirm following this. Whereas in some hospitals, always chest x-ray is done first for all the patients. Now, assessing bubbles at the end of the tube is unreliable because the stomach could also contain air, and it could be falsely interpreted as respiratory placement. So yes, assessing bubbles by putting the end of NG tube underwater is unreliable because the stomach can also contain gas, gases or air, and it can be falsely interpreted as respiratory placement. So yes, some people have this habit, or this is also practice sometimes, like people putting the other end of the NG tube underwater and checking for bubbles. So it is unreliable because even stomach can contain gases or air, and it will, it will also show up in the form of bubbles, and it can be falsely interpreted as if it is inside the trachea. So yes, and one other widely practiced method, which is also not accurate, is auscultatory method, using a stethoscope to auscultate air injected into the NG tube, also known as whoosh test, is not accurate. It's not accurate. Accurate is only chest x-ray. Okay, so this was about NG tube placement. Let's let's go on to the next scenario. So now we have a case of refeeding syndrome. Here is a 21-year-old woman with BMI of 12 who refuses to eat and was admitted to medical ward for feeding through NG tube. So this is clearly a case of refeeding syndrome, and we will have certain electrolyte abnormalities in this patient. Uh, let's see the refeeding syndrome now. So a refeeding syndrome occurs when a malnourished person is given high carbohydrate load. This may result in falling phosphate, magnesium, and potassium levels. It occurs within 4 days of starting to refeed. So refeeding syndrome, it occurs when a malnourished person is given high carbohydrate load. It results in reduced phosphate levels, reduced magnesium levels, and reduced potassium. These are the electrolyte abnormalities. and it occurs within 4 days of starting to refeed. Now, this electrolyte abnormality, which occurs during refeeding, can be explained by certain pathophysiological explanations. We have to understand what happens during fasting and what happens during refeeding. So, during the time of fasting, the body switches its main fuel source from carbohydrates to fat tissue and amino acids. Intracellular minerals tend to be depleted during this period, however, the serum levels remain normal. Insulin is suppressed as the body is in a fasting state. Whereas during refeeding, there is an immediate shift from fat to carbohydrate metabolism. A glucose load would result in release of insulin and increased cellular uptake of glucose. Not just glucose, there will be increased cellular uptake of glucose, phosphate, potassium, magnesium. Glucose, magnesium, phosphate, potassium, which results in quick depletion of serum levels of these electrolytes or minerals. Now, to prevent refeeding syndrome, feeds are usually given slowly with supplements of potassium, magnesium, and phosphate. So, during fasting, body's main fuel source switches from carbohydrate to fat, tissue, and amino acids. So, during this phase of fasting, intracellular electrolytes or minerals are depleted. However, serum levels are normal. Insulin is suppressed. Now, during refeeding, what happens during refeeding? During refeeding, there is an immediate shift from fat to carbohydrate metabolism. A glucose load or carbohydrate load, it would result in insulin release and increase cellular uptake of glucose, phosphate, magnesium, and potassium, which results in quick depletion of serum levels of these electrolytes. Therefore, this is important to prevent refeeding syndrome. Feeds are usually given slowly along with supplements of potassium, magnesium, and phosphate. This is the way to avoid, to prevent refeeding syndrome. That is to give the feeding slowly, to give the feed slowly along with supplements of potassium, magnesium, and phosphate. Because during fasting, during the time of fasting, the body switches its energy source from carbohydrate to fats and amino acids. So our metabolism changes, and during this time the intracellular level of these electrolytes and minerals gets depleted. However, the serum levels tend to remain normal and insulin is suppressed. Insulin level is low because the body is already in a fasting state. Whereas during the time of refeeding, there is an immediate shift from fat to carbohydrate metabolism, and a carbohydrate load or a glucose load would result in immediate release of insulin and increased cellular uptake of glucose, magnesium, phosphate, potassium, which results in quick depletion of these electrolytes from the serum and hence the reducing levels. So, when a malnourished person is given a high carbohydrate load, it results in this refeeding syndrome. It results in reduced serum electrolytes such as magnesium, phosphate, and potassium, and it usually occurs within 4 days of starting the feed. Can be avoided by giving feed slowly, associated with supplementation of phosphate, magnesium, and potassium. Let's move to the next scenario now. During the time of massive blood transfusion, there will be low calcium, low magnesium, and there will be high potassium first, followed by low potassium. So this is just an additional important point during transfusion. Massive blood transfusion. There will be hypocalcemia, hypomagnesemia, hypomagnesemia, and hyperkalemia, followed by hypokalemia. Hypocalcemia, hypomagnesemia, hyperkalemia, followed by hypokalemia in case of massive blood transfusion. Refeeding syndrome, hypomagnesemia, hypophosphatemia, hypokalemia, and also hypocalcemia. Calcium level would also fall, but yes. Tumor lysis syndrome, hypocalcemia, hyperkalemia, hyperphosphatemia, and hyperuricemia. Villus adenoma, hypokalemia, and hypoproteinemia. Anorexia nervosa, hypomagnesemia, hypokalemia, hypophosphatemia. Okay, that is same. Okay. Let me go through the scenario. Now, here we have a case of acute chest syndrome. Here is a 25-year-old African English male brought to the ER with fever, chest pain, shortness of breath, cough. Symptoms began around 3 days back, have been becoming progressively worse. Chest pain is severe, and chest pain is even worse when breathing in. He has sickle cell disease, history of admissions for painful crisis. Temperature is 38.5, pulse is 111, blood pressure is 130 by 85, respiratory rate is 20, saturation is 88%. Auscultation reveals bilateral fine crackles with diminished sounds over both bases. Chest X-ray shows bilateral basilar airspace opacities and bilateral pulmonary edema. What is the likely diagnosis here? It's acute chest syndrome. So yes, let's Acute chest syndrome is a serious complication in those with a sickling disorder. It mimics pneumonia, and early recognition is important as it a leading cause of death in patients of sickling disorder. It's often caused by an infection, most commonly by pneumonia, but can be precipitated by conditions like fat embolism, thromboembolic disease, or vascular injury. In this, the patient the patient needs to receive adequate analgesia, oxygen, empirical antibiotics, and blood transfusions. The caution needs to be exercised with IV fluid hydration as it could further exacerbate the pulmonary edema. So the patient needs to receive adequate analgesia, oxygen, empirical antibiotics, and blood transfusions. Caution regarding IV fluid hydration as it could aggravate or exacerbate pulmonary edema. Painful crisis is like a pain experience in a vaso-occlusive crisis resulting from oxygen deprivation of tissues and avascular necrosis of the bone marrow. And risk of vaso-occlusive episodes is increased by exposure to cold, fever, and dehydration. Around 90% of hospital admissions for patients with sickle cell disease or sickling disorder are for painful crisis. Hydroxycarbamide can reduce the frequency of painful crisis in sickle cell disease. However, it is unlicensed in the UK. So avoid exposure to cold, fever, dehydration and stress. Increased fluid intake, warmth and rest. Simple analgesic ladder is appropriate, starting with PCM or any other such painkillers, or we can use weak opioids like codeine for patients with mild pain. Always look for a cause, that is infection. Admit the patients if the pain does not subside promptly, or if there is need for strong opioid treatment, or if fever, pallor, signs of respiratory compromise are there. Benzodiazepines may be helpful to reduce anxiety. So, acute chest syndrome is a serious complication in those with sickling disorder. It can appear to be like pneumonia, can mimic it, and it is often caused by such an infection, most commonly pneumonia. But it can be precipitated by other conditions as well, such as fat embolism, thromboembolism, or any vascular injuries. And early recognition is very important as it is a leading cause of death in patients with sickling disorder. Patients need to receive adequate analgesia, oxygen, empirical antibiotics, and blood transfusions. Caution should be there regarding IV fluid hydration, and it can further aggravate pulmonary edema. Okay, so here we'll take a break for a while and I'll get back. Okay, so let's move on to the next scenario here. So now we have a case of intracerebral hemorrhage. Here is a 39-year-old lady presenting in with sudden onset of headache, weakness in the left arm, left leg, and left side of her face. No previous medical history, not on any current medications. Blood pressure is 200, 120, clearly raised. Her pulse rate is 101, respiratory rate is 14, temperature is 36.8. Airway has been secured, oxygen is being supplied, and some CT scan images are being shown, which I can see here. And it clearly shows internal bleeding or intracerebral hemorrhage. The images, as I said, shows intracerebral hemorrhage. Now, in this case, rapid control of blood pressure for people with acute intracerebral hemorrhage is considered where the presentation is within 6 hours of symptom onset and the systolic blood pressure is between 150 and 220. There are few instances where you would not offer rapid blood pressure control in an acute intracerebral hemorrhage, but it is not that relevant at this stage. So such this patient needs labetalol to be given, where is the most appropriate initial management in this case. So important thing is rapid control of blood pressure in patients with intracerebral hemorrhage is considered where presentation is within 6 hours of onset of symptoms. Systolic blood pressure is between 150 to 220 mmHg. So rapid control of BP in patients with intracerebral hemorrhage can only be done when the presentation is within 6 hours of the onset of symptoms. A patient comes to you within 6 hours of onset of symptoms, or if the systolic blood pressure is between 150 to 220 mm Hg. Now, for cerebral edema, mannitol is used. Mannitol is used. It's an osmotic diuretic. Which elevates the plasma osmolality and enhances the flow of fluids from the tissues or the cells into the blood vessels. And that is how it uh, causes shifting of the fluids and reduces the edema. Because it is an osmotic diuretic and it increases plasma osmolality and it increases movement of fluids from tissues into the blood vessels. Now, studies have shown that using mannitol injection in intracranial bleeding can initially decrease edema, but after the edema subsides, the volume of hemorrhage increases. So, initially, mannitol injection can decrease edema in cases of intracranial bleeding, but after edema subsides, volume of hemorrhage increases. So this is also important to know. And drugs like aspirin and alteplase are used in ischemic strokes only after intracranial hemorrhage is excluded. They are not used in case of intracranial hemorrhage. They are only used in ischemic strokes. And prothrombin complex concentrate is used together with IV vitamin K to reverse the effect of warfarin, lowering the INR and normalizing the clotting levels in primary intracerebral hemorrhage. So, in intracerebral hemorrhage, prothrombin complex concentrate plus vitamin K IV given to reverse effect of warfarin, lowering INR and normalize clotting level. So, in case of intracerebral hemorrhage, rapid control of blood pressure for people in this condition with acute intracerebral hemorrhage is considered only when presentation is within 6 hours of the onset of symptoms. Patient presents to you within 6 hours of onset of symptoms and the systolic blood pressure is between 150 to 220 mmHg. 150 to 220. Now, mannitol is used in cerebral edema. It is an osmotic diuretic which increases the plasma osmolality, which increases the flow of fluids from the intracellular or from the tissues into the blood vessels, thereby reducing edema. But studies have shown that initially mannitol, when given in intracranial bleeding, can reduce edema, can decrease edema, but later on, after the edema subsides, it can actually increase hemorrhage, the volume of hemorrhage. It can actually increase the volume of hemorrhage. And aspirin and alteplase, drugs like that are given in ischemic strokes. They are not given in intracranial hemorrhage. Prothrombin complex concentrate are used together with intravenous vitamin K to reverse the effect of warfarin, lower INR, and normalize clotting levels in primary intracerebral hemorrhage. Now consider rapid blood pressure lowering for people with acute intracerebral hemorrhage who do not have any of the exclusions. We should not give rapid blood pressure lowering to people who have an underlying structural cause. For example, they have a tumor or AV malformation or aneurysm. They have a score of below 6 on GCS scale. On GCS, score is less than 6. Or they are going to have early neurosurgery to evacuate the hematoma. Or they have a massive hematoma with poor expected prognosis. Rapid blood pressure is considered for people with acute intracerebral hemorrhage who presents within 6 hours of the symptom onset, who have systolic blood pressure between 150 and 220. GCS score less than 6, underlying structural cause, or are going to have a neurosurgery or massive hematoma with poor expected prognosis. These are like contraindications of providing rapid blood pressure lowering. In this case, mannitol is a part of management. Mannitol can be given, it should be given, but it is not the most appropriate initial management. Most appropriate would be labetalol. Mannitol is a part of management. It will be done, should be done, but it is not the most appropriate initial management. Labetalol is the initial management. Prothrombin complex concentrate with vitamin K can be given. Aspirin, alteplase, ischemic strokes, mannitol and edema. But yes, later on it can increase the volume of hemorrhage. So labetalol. Labetalol is a non-selective beta blocker with concurrent alpha 1 blocking, which produces peripheral vasodilation. It is indicated to treat hypertension of pregnancy and intravenously for hypertensive emergencies. So, labetalol has to be given. Hypertension of pregnancy or intravenously given for hypertensive emergencies. It is non-selective beta blocker. Let's go to another scenario. So here we have a scenario in which a 34-year-old man is brought into the ER after accident. He has blunt injuries to his chest without any penetrating wounds. His observations were initially normal. GCS is 13. After an hour, his GCS drops to 9. Respiratory rate is 4. Heart rate is 120. Saturation is 92. Blood pressure is 100 by 60. So, GCS here is 9, and respiratory rate is 4, heart rate is 120, saturation is 92, blood pressure is 100 by 60. So in this case, administering high flow oxygen is the most appropriate initial action, because here the GCS is greater than 8, so we should not go for intubation. We should rather administer high flow oxygen. GCS is greater than 8, so intubation is not indicated. If they would be asking for the most appropriate management or most appropriate action, that would be intubation and ventilation. Because here certainly there is it's a case of respiratory failure, and respiratory rate is 4 here. So we will definitely have to intubate and ventilate this patient, but not right away. I mean, we have to do it, but while we are preparing for it, we have to provide oxygen to the patient. So they have used initial in the question. Most appropriate initial action. That's why we will go with administering high flow oxygen. So while we are preparing for intubation and ventilation, meanwhile, we'll give high flow oxygen to the patient. That will be the most appropriate initial action. If this would not be in the options, then we can go for intubation and ventilation. Or if initial was not there, then most appropriate action would be intubation ventilation. A massive hemorrhage or ruptured diaphragm may require tracheal intubation. However, the question is for the most initial management, of which high flow oxygen should be the first thought. High flow oxygen should be given to maintain oxygen saturation at 94 to 98%. If ventilation is still inadequate, then we have to assist with bag and mask or consider tracheal tube. The most appropriate initial management will be high flow oxygen therapy to maintain the saturation between 94% to 98%. But certainly we have to intubate and ventilate the patient because it is a case of respiratory failure. Respiratory rate is very low, it is 4, and most appropriate management would be intubation and ventilation, but most appropriate initial management would be high flow oxygen so as to maintain the saturation between 94% to 98%. And still, uh, if ventilation is still inadequate, then we have to assist with bag and mask ventilation or tracheal tube. First, we'll give high flow oxygen to maintain the saturation between 94 to 98%. If ventilation is still inadequate, then we have to assist with bag and mask ventilation, or we have to put the patient on ventilator, tracheal tubing, intubation, and ventilation. So it's oxygen administration or high flow oxygen before intubation and ventilation. That is the initial action. As here the oxygen saturation was 92%. Glasgow Coma Scale (GCS) is used to measure a person's level of consciousness in acute medical emergencies or trauma. Lower the score, the more severe is the situation. Eye-opening verbal response and motor response. Eye-opening 4-3-2-1, verbal response 5-4-3-2-1, motor response 6-5-4-3-2-1. Eye-opening eyes are opening spontaneously 4, eyes are opening to speech 3, eyes are opening in response to pain stimulus 2, no response 1. Verbal response oriented meaningful conversation 5, confused uh, res- confused respond to questions but disoriented and there is confusion, inappropriate sentences are being spoken. Then 4, inappropriate words, random speech, no conversational exchange. Then it is 3, and if patient is making incomprehensible sounds, moaning but no words. 2, no verbal response. 1, motor response obeys commands. 6, obeys commands. 6, localizes to pain. Localizes to pain, that is brings hands up beyond chin when supraorbital pressure is applied. When supraorbital pressure is applied, then the patient brings his or her hands beyond chin. That is localizes to pain. Then flexes to withdraw from pain. Pulls away when the nail bed is pinched. Now, if the patient flexes to withdraw from pain, that is, patient pulls away when the nail bed is pinched. It is 4. Abnormal flexion in response to pain. 3. Abnormal extension in response to pain. 2. No motor response. 1. Let's move further. Now, here we have a 69-year-old woman who is brought to ER complaining of severe substernal pain, which started suddenly radiating to her back. She is known to suffer from hypertension and diabetes. She's a heavy smoker. On examination, her pulse is 100. Her blood pressure on right arm is 170 by 115. Her left arm has blood pressure of 130 by 90. Breath sounds are normal. ECG is performed, which shows normal sinus rhythm. Intravenous diamorphine has been given. What is the single most appropriate management? Single most appropriate management would be to give a beta blocker like labetalol here. Labetalol is given intravenously for hypertensive emergencies. So, also here the patient is having aortic dissection. The sudden pain which radiates to back and the large difference between blood pressure of the right and left arm are pointing towards aortic dissection. So her hypertension needs to be addressed immediately to reduce further damage. This is done by introducing intravenous beta blockers like levotalol and should ideally be started on suspecting an aortic dissection rather than after confirming it. Beta blockers have the advantage that it reduces the force of ventricular contractions, which further reduces harm. A systolic pressure of between 100 and 120 is ideal and should be sought for. This is a case of aortic dissection, and in this there was sudden pain, substernal pain radiating to back, and large difference between left and right arm blood pressure. Large difference between the blood pressure of left and right arm. Large difference means more than 20 mmHg. So these are the clues which indicate this is a case of aortic dissection. Now her hypertension needs to be addressed. So in case of hypertensive emergencies, intravenously uh, beta blockers should be given. Example, labetalol. And it should be started just when aortic dissection is suspected rather than after confirming it. And a systolic blood pressure of between 100 to 120 is ideal. So systolic BP should be around 100 to 120, should be sought after. Aim. So beta blockers have an advantage that it reduces the force of ventricular contraction. So it reduces further harm. So that is the thing. I'll just get back in a while. So in case of aortic dissection, the clues are sudden severe chest pain radiating to back, large difference between the blood pressure of right and left arm, which is more than 20 mmHg, pre-morbid conditions like uncontrolled hypertension, smoking, etc. And investigations which we have to carry out in a case of aortic dissection are ECG, but in one third of the cases, ECG can be normal, or there can be signs of ischemia or MI. And secondly, we can carry out chest X-ray, in which mediastinum will be can be wide, or we can carry out CT angio for a definitive diagnosis. Or in case of patients who are not stable, we can carry out a transesophageal echocardiogram, transesophageal echo, in case of hemodynamically unstable patient. Management would be to give beta blockers even on suspicion of aortic dissection, with an aim to achieve target systolic BP between 100 and 120. And these beta blockers, they reduce cardiac motility, so they reduce the cardiac mortality. They reduce the force of ventricular contraction and reduce mortality. Yes, they reduce cardiac motility, and hence they reduce the harm and thereby the mortality or the morbidity caused because of it. So in this, the investigations, first of all, the clues of aortic dissection are sudden severe chest pain radiating to back, large difference between the blood pressure of right and left arm, more than 20 mmHg, history of uncontrolled hypertension, smoking. Investigations which we can carry out is our ECG, which can be normal and can show ischemia or MI, chest X-ray showing wide mediastinum, CT angiography, which is like the gold standard for definitive diagnosis. In case of carried out in stable, hemodynamically stable patients, transesophageal echo in uh, hemodynamically unstable patients. Management is by beta blockers with an with target BP, systolic BP of 100 to 120, and they also reduce cardiac motility. So yes, investigations are ECG, chest X-ray, CT, angio, gold standard for definitive diagnosis. Then trans esophageal echo, unstable patients, X-ray wide mediastinum. Okay, so now we'll move on to the next scenario. But before we move further, we can study a little more about thoracic aortic dissection. It occurs in poorly controlled hypertensive patients. Episode resembles MI with sudden onset of extremely severe tearing chest pain that radiates to the back and may migrate down. And large difference in blood pressure in the upper extremities. So these are the points to remember in case of thoracic aortic dissection. Now for investigations, as we discussed, chest x-ray, wide mediastinum, ECG, MI or ischemia, CT angio, gold standard, definitive diagnosis, transesophageal echo is appropriate in hemodynamically unstable patients. Now, management. IV labetalol on suspecting aortic dissection. Target systolic BP 100 to 120. To reduce further harm. As a rule, with many exceptions, dissection of ascending aorta are treated surgically. Dissection of descending aorta are treated medically with control of hypertension in the ICU. So there are certain classifications like Stanford classification, which is having type A and type B. Type A is involving ascending aorta, 2/3 of cases. Surgical management, BP control, target systolic 100 to 120. Type B involving descending aorta, 1/3 of cases. Descending aorta, distal to left subclavian origin. Distal to left subclavian origin. Reduce blood pressure with intravenous beta blockers like labetalol. So medical management, reduce blood pressure by IV labetalol. Second classification is DeBakey classification. It has type 1, type 2, and type 3. Type 1 originates in ascending aorta, propagates to at least the aortic arch. Propagates to at least aortic arch and beyond it distally. Type 2 originates in and is confined to ascending aorta. Type 3 originates in descending aorta. Originates in descending and rarely extends proximally but extends distally. People with Marfan syndrome and Ehlers-Danlos syndrome are at higher risk of developing aortic dissections. So this was about the thoracic aortic dissection. I think we discussed enough about this. Let's move to a different scenario now. Now, we have a 29-year-old woman who is admitted in the hospital following a suicide attempt with amitriptyline. She is unconscious, her pupils are dilated, ECG reveals prolonged QT interval, broad QRS complex, her blood pressure is 85 by 60. ABG or arterial blood gas shows pH 7.05 and lactate is 6.6, that is normally between 0.6 to 2.4, and the pH is usually between 7.35 to 7.45, or roughly we take 7.4. So pH is 7.05, lactate is 6.6, BE is minus 13, normal is minus 2 to plus 2. So most appropriate management would be what? Most appropriate management would be to give IV fluids to the patient and sodium bicarbonate, because clearly she's in acidosis, and we have to give sodium bicarbonate. So this is a case of tricyclic antidepressant overdose. There is no specific treatment for tricyclic antidepressant overdose. Administering IV fluids as a bolus and administering sodium bicarbonate is the single best management for this patient, with the aim to achieve an arterial pH of 7.5 to 7.55, and sodium bicarbonate is given 50 ml of 8.4%, is given intravenously. 50 ml sodium bicarbonate 8.4%. 50 ml of 8.4% sodium bicarbonate is given along with IV fluids to achieve an arterial pH of 7.5 to 7.55. ECG monitoring is required until the ECG changes have disappeared for 12 hours. Intravenous benzodiazepines are only required if there is a seizure. Activated charcoal via nasogastric tube is part of the management, but it is likely that it has been fully absorbed based on the symptoms of this patient. This is a case of tricyclic antidepressant overdose. Amitriptyline was used. So there is no specific treatment for tricyclic antidepressant overdose. Single best management is to administer IV fluids, boluses, plus administer 50 ml of 8.4% sodium bicarbonate. Target arterial pH is 7.5 to 7.55. This administer 50 ml of 8.4% sodium bicarbonate intravenously. Apart from this, ECG monitoring done until ECG changes have disappeared for 12 hours. ECG monitoring is required until ECG changes have completely disappeared for 12 hours. And intravenous benzodiazepines are required only if seizure occur. Activated charcoal via NG tube is part of the management, but it should be done timely. But should be done timely before drug is absorbed fully. Tricyclic antidepressant overdose should always be considered potentially life threatening. Sometimes these patients can deteriorate very rapidly, sometimes even within 1 hour of ingestion. Features now clinical features would be dilated pupils, dry mouth, dry flushed skin, urinary retention, drowsiness, altered mental status, leading to coma and hypotension. ECG monitoring for tricyclic antidepressant overdose is essential. The important ECG findings are QRS widening and broad complex tachycardias may occur, which are life threatening. QRS widening. More than 100 ms and broad complex tachycardia, life threatening. So ECG monitoring should be done until ECG changes completely disappear for 12 hours. In ECG findings, QRS widening is suggestive of TCA poisoning. QRS widening is suggestive of TCA tricyclic antidepressant poisoning. Broad complex tachycardia may occur, which are life threatening. And ABG shows metabolic acidosis. Now, management In management, we have to first maintain airway and adequate ventilation. Second, we have to give sodium bicarbonate. A young child that takes his or her grandparents' medication who later on becomes drowsy and lethargic with a dry mouth and dilated pupils is a case of TC poisoning. An elderly person who has a terminal illness wants to take his or her own life, who feel thirsty, flushed, pupils are dilated is a case of TC poisoning. These tricyclic antidepressants are prescription only medication, so you should think about how the person in the stem obtained the medication before you choose an answer. Because these tricyclic antidepressants are prescription drugs. So one should think about how that person who is obtained, uh, who is brought, how that person obtained the medication. So a young child which took his or her grandparents' medication, later on becoming drowsy and lethargic with dry mouth and dilated pupils, or an elderly person who has a terminal illness wants to take his or her own life, feeling thirsty, flushed, and pupils are dilated. Both are cases of TC poisoning. Clinical features are very important. There will be dry mouth, dilated pupils, dry flushed skin, urinary retention, drowsiness, altered mental status, hypotension. Investigation, ECG, ECG monitoring, very important until ECG findings are completely disappeared for 12 hours. ECG main important findings suggestive of TC poisoning are uh, QRS complex widening, QRS widening, and broad complex tachycardia can be life threatening. ABG should be done. ABG will indicate metabolic acidosis. And management, a single best management is to give IV fluid boluses plus sodium bicarbonate, 50 ml of sodium bicarbonate, 8.4%. 50 ml of 8.4% sodium bicarbonate intravenously. Uh, so we have to maintain airway and adequate ventilation of the patient, and sodium bicarbonate, another thing which is important. So yes, that was about TCA overdose or tricyclic antidepressant overdose. It is a potentially life-threatening case. Now, activated charcoal via NG tube is a part of management, but it should be done timely before the drug is completely absorbed, which we can assess based on the symptoms of the patient. Now we will move on to another scenario. Now here we have a 33-year-old woman who has a major hemorrhage during her C-section delivery. She was transfused with 16 units of pegged red blood cells, 4 units of platelets, 8 units of plasma during the operation, had hysterectomy. So the electrolyte abnormalities in this patient can result from the massive blood transfusion. Main uh, electrolyte abnormalities in case of massive blood transfusion are hypocalcemia, hypomagnesemia, hyperkalemia, and then hypokalemia. Massive blood transfusion is defined as replacement of more than 1 times of total blood volume in 24 hours or 50% of blood volume in 4 hours. Or in children, transfusion of 40 ml per kg, more than 40 ml per kg. Over 1 month old is 80 ml per kg. Okay, so it's a case of massive blood transfusion. Massive transfusions are when we replace 10 units of PRBCs within 24-hour period, or one half of the blood volume of the person within a 24-hour period in response to massive and uncontrolled hemorrhage. Such massive blood transfusion can result in electrolyte disbalances or disturbances. One of the complications of massive blood transfusion is hypocalcemia, which results from citrate toxicity. Each unit of blood contains around 3 grams of citrate, which can bind easily to calcium. Healthy adult can usually metabolize 3 grams of citrate in their liver within 5 minutes. However, if the transfusion rate is greater than 1 unit per 5 minutes, citrate can accumulate and bind to calcium, leading to hypocalcemia. Hypomagnesemia can also result from citrate toxicity, but it is uh, not necessary. It will always be in the options. Other electrolyte imbalances include hyperkalemia and hypokalemia. Hyperkalemia can result if large amount of blood is given quickly, as there is increased cell turnover, which results in potassium released from cells. Hypokalemia can result if the red blood cells begin active metabolism and increase uptake of potassium. Metabolic alkalosis can also occur as citrate is metabolized to bicarbonate, which raises the pH. Okay, so citrate toxicity is also an important part of like massive blood transfusion. So in massive blood transfusion, first we will define massive blood transfusion. It is when we replace 10 units of PRBCs within 24 hours or one half of blood volume of the person within 24 hours in response to massive and uncontrolled hemorrhage. Such massive blood transfusions can lead to electrolyte disturbances. So, what can happen? Hypocalcemia can happen. Why hypocalcemia would happen? Because each unit of blood has 3 gram citrate, which can bind calcium and deplete it if not metabolized in time. Second is hypomagnesemia. It also occurs due to citrate toxicity. Then hyperkalemia and hypokalemia. Increase cell turnover, leading to potassium release from cells. Hypokalemia, if RBCs begin active metabolism and intracellular uptake of potassium. Another thing which happens is metabolic alkalosis. Because citrate is metabolized to sodium bicarbonate. Or let's just say citrate is metabolized to bicarbonate, which increases the pH, leading to metabolic alkalosis. So these are the things which we should remember about massive blood transfusion. So this was it for today. And till next time, take care of yourself. I hope It was a productive session for you. It was for me. And see you. See you soon.